Screen 2. Right, so I get confused with these windows. So can you see my screen now? Right, cool. Right, okay, here we go. So I can only see Lynn at the moment. For some reason, I can't see anyone else. But if you've got any questions, Sophie, as we go along, I know you've got no microphone, but just put them in the chat if you've got any questions. And if Lynn can stop me because I can't see the chat at the same time, then we can go back. So what I'm going to just relatively quickly run through is this data pack that we've created for Wetherby Local Care Partnership Primary Care Network. So this is part of the population health management approach to people living with frailty in the city of Leeds. And population health management is essentially using data to create cohorts of people with specific or similar conditions that we will want to identify, and then perhaps look at some interventions for those people. So the data comes from something called the Leeds data model, which is a linked data set that we've got in the city. So we're pretty lucky to have it. It's what we call pseudo-anonymized. So we can't identify people from this linked data set, but we are able to track their care and their kind of touch points of care around the city. So we can't say that this particular patient is Mary and she lives on this particular street. We don't know that, but we can. So we can't ever identify people. So there are some local care partnerships or primary care networks that we've created in the city, and we're able to slice and dice our data into those primary care networks. And everybody likes to see where we are in relation to our peers. So this is a couple of simple charts that just says where is Wetherby in relation to the other primary care networks in Leeds in terms of frailty. So as you can see, Wetherby is right at the top. So Wetherby has the highest prevalence of moderate and severe frailty of all of the local care partnerships or primary care networks in Leeds. So just less than 6% of all the people that live in Wetherby, so about just over 2,000 people, are in our frailty cohort. So compared to other primary care networks, that's a lot. And then down here on the right, we actually know how many people are in those particular cohorts. So there's just short of 1,500 in that moderate frail cohort. So that's quite a lot of people. This is a chart that shows the difference between males and females, and also splits it down into age. So we probably knew that there were going to be more females than males because females live longer. So that's just a fact, really. And then we're also able to kind of standardize for age. So we know that age is a factor in frailty. So we're able to standardize that. So kind of remove that as a factor, and then we can reorder our primary care networks. So Wetherby then becomes, so it kind of moves down slightly, but it's still in that middle third for moderate and severe frailty. And then one of the other interesting things that we can do is also find out by index of multiple deprivation decile. So index of multiple deprivation, or IMD for short, essentially takes a number of indicators and says how deprived a particular area is. So we're looking at things called lower level super output areas here. So each primary care network is made up of a number of LSOAs, and each LSOA has a deprivation decile attached to it based on the people and the kind of the census data that we know about those people. So actually, and this is quite interesting and very different for the rest of the primary care networks in Leeds, the highest proportion of people in Wetherby with moderate and severe frailty live in the least deprived areas. So on that chart on the bottom, decile 1 is the most deprived and decile 10 is the least deprived. And we tend to see a completely different pattern, that most people with frailty live in the most deprived areas. But in Wetherby, you know, Wetherby is different, and that could be a good thing, could be a bad thing. It is different compared to Chapeltown, for example, compared to Beeston. It's a very different demographic makeup, and I guess we kind of knew that, but that's quite an interesting chart to show that. So within the Leeds data model, we have some spend information. It's not as good as we would like, but we're working on improving that all the time. But people could kind of get behind how much money we spend on people within these particular cohorts. So just to kind of explain what this particular chart shows. So the vertical columns are our moderate and severe frail cohorts, and then across we've broken those cohorts down by age. So our kind of middle row is our older adults, age 60 to 74. So we know in Wetherby, with the people with moderate frailty, so this particular box here, the people aged 60 to 74 with moderate frailty, there are 357 of those people. And in the financial year 2018-19, we spent £815,000 on them. And dividing one by the other, we can say that we spent £2,286 per person per year on those people who had who were moderately frail. So we can then compare that spend to the Leeds position. So on this chart, the black box that's round here and round here, that's the Leeds position, and the kind of mustardy yellow shading is the Wetherby position, or that particular PCN position. So what we're saying here is that actually for our older adult population in Wetherby in that year, we spent less on those people than the Leeds average. So really, that is a question for the people in Wetherby. Is that good? I'm not particularly sure whether it's good or bad, but that's that curious question. How can we be curious and ask more questions of this data? So we can say, so up here, in our moderate frail cohort of our younger adults, there were 59 of them, but we spent loads more money on them. So there's a few people that we're spending a lot of money on. So that might be something of interest to be a bit more curious about and find out, well, why is that? So those are the sort of questions that I'm kind of getting people to think about as we go through. Just why is that? You know, do we need some more information? How can we understand that further? So that's where we are on spend. So pretty much across the board, Wetherby is spending less on its frail population than the Leeds average. Again, is that good? Is that the best care that we can possibly deliver? What is driving that cost? And then we can also break that down into the number of long-term conditions that people have. So we know how many long-term conditions everyone in Leeds has, and then we can break that down again into those numbers of conditions and by age. So again, we're seeing quite clearly that in our kind of older adults, 60 to 74, we're still with 2 to 5 long-term conditions, we're spending less than that Leeds average. And those those similar people with kind of more long-term conditions, we're still spending less. So, you know, we could possibly assume that because Wetherby is slightly more affluent, people are more healthy, they have better opportunities, that maybe those are some of the reasons that's driving that the cost to be lower. But, you know, I'm not sure. Those are just my kind of thoughts. So the way that we identify frailty in leads is something we use something that is driven by coding that happens in primary care. So whenever somebody pitches up or has a telephone conversation or video conversation now with a primary care professional, they would start to code things about the conditions that that person is presenting with. And all of those conditions, as you might know, have what we call read codes attached. So there's a read code for absolutely anything. And some work was done by some academics to say, what are those read codes that would kind of come together to say that these people are frail? What are those frailty related read codes? And then they did some work. So they pulled like couple of thousand read codes and said, okay, how can we then aggregate those into some higher level measures? So this electronic frailty index, or EFI, is the thing, kind of the algorithm that we use in leads to identify frailty. And on the left here in this column are those frailty deficits. I always say this, that deficit is a very negative word, and in leads we're all about that kind of strength-based conversation. So if you want to call it a deficit, that's fine, but it's more of a measure. So behind all of those 36 measures, there are a number of read codes, and I can provide you kind of that added level of granularity, if you like. But essentially, we've got the leads position of moderate and severe frailty, the Wetherby position compared to the leads position, and then the difference. So hopefully the way that we've set up the shading is the kind of the darker, more prominent colours highlight those measures of frailty that are more prevalent in Wetherby. So just as a summary, we've got here mobility and transfer problems, social vulnerability, dizziness, and urinary incontinence are the things that perhaps the data is saying we should look first here at people with those characteristics. And this is just a slightly different way of showing that same data. So that leads position is that middle bar at 0%, and anything to the right has a higher prevalence within Wetherby than the leads position, and anything to the left has a lower prevalence. Now, we get a lot of challenge is the right word around, oh, that doesn't look right for my primary care network. And that's fine. And again, it's good to be curious about the data. So these measures are as good as the coding that goes on in primary care. So some primary care networks have, so for example, housebound. We know that central PCN, their prevalence of housebound people is way to the right, and there's a higher prevalence. So it's interesting that in Wetherby we have a high prevalence of frailty. We've got a higher kind of average age. The people in Wetherby are older, but they're less housebound. So I suppose that's a really good position that they are up, out and about. So again, the big bars on the right are the things that we should probably start to look at first if we wanted to create a cohort of people to design with them some interventions or some support or some proactive care. And again, that's our severe frail cohort. So there's kind of slightly bigger bars as people get more frailty deficits, and those bars we tend to see get bigger. So we can also compare our PCN to other PCNs, because we always like to compare ourselves to others. And again, here's some kind of prevalence and spend information. So if we look at Wetherby, we can compare it to our other, a selected few other PCNs. But we can see here that there's an overall prevalence of 35.1% in mobility and transfer problems. So again, it's just kind of pointing us in the direction of places that we could start to look. And you could say, well, why is Wetherby so different to Yeadon? What's different in Yeadon to Wetherby? Could we learn anything from what's going on in Yeadon? But mobility and transfer problems, I think, in Wetherby, and we've talked about this at LCP meetings before, It tends to be the kind of rurality issue within Wetherby, public transport getting to access services. So that could be something that we could look at. And then this might be a bit, you might need a bit more time to study this, but this is putting everybody in Wetherby into how much they're costing. So again, we've got 10 deciles of cost. So essentially we've taken everybody in Wetherby with their cost and put them into a big order, and then chunked it into tenths. So we can see that in the highest cost decile, which is decile 10, we've got 93 people in there. Their average age is 78. They've got just over 5 long-term conditions. They've got 10 frailty deficits, and there's an average kind of deprivation decile of 8.4. So that means it's those people are living in the least deprived areas of the city. So again, the red shading hopefully draws the eye to the things that are driving the costs. So within decile 10, and we see this all the time. So there's a massive increase in cost in acute non-elective. So that's your kind of emergency admissions. But if that cost is being driven by these things down here, what could we do with our 93 people who have these conditions to essentially reduce the number of times that they need to go into hospital in emergency? This PHM approach is around that proactive care. How can we ask them what do you need to help you manage your condition, to mean that you don't go into hospital in an acute non-elective way. And then finally, this is kind of the beauty of the Leeds data model, this linked data set that we've got. So we're able to track a person's care around the city and to visually represent it like this. So we have data from these settings on the left here. So we've got GP stuff, urgent care, outpatients, that sort of stuff, community, and we can take a person. So obviously to create this slide, we've picked someone that's got a lot of contacts and is quite interesting. Otherwise, it might be a bit dull. But we can kind of read this person's journey around the city. So we don't know that this person is called Emma. We've just made that up. But we do know that this person is a female and is 59. They have 12 frailty deficits. They've not got many long-term conditions, and they're kind of in that middle, not particularly deprived and not particularly undeprived. But we can see, I mean, this is quite interesting. So this inpatient non-elective, what is going on here? There's some, this is possibly driving that cost that we just saw, that this person is going into hospital or is in hospital a lot. They've had a number of outpatients appointments, but they're still kind of in hospital. There's one GP appointment there, a kind of cluster there. So we can see that they've been in hospital quite a lot, but then they seem to come out with some community care here and here, and then a lot of community care here. So if we were able to proactively set to reduce that non-elective admission into hospital and manage this person in the community, that's probably better for the person. So what we're trying to say here is, this is a kind of a pictorial view of this person's care. Is it the best care that we could have given to this person? Could we have improved it? And then the final slide is someone that's got more severely frail. So again, we don't know that this person is called Alice. We've made that up, but we do know that she is older than Emma, still female, more long-term conditions, but living in an even least deprived area. And this person has got a lot of community care and has got a very different, not so much non-elective, but again, it's purely a visual representation of this person's care for this time period. And again, is it good? I have no way of knowing if that's good, but that's hopefully kind of sparks those conversations about why and to be curious about the data. And just so this is the final slide. So these are the practices that we've got in the Wetherby Primary Care Network. Just before you say that that doesn't look like the total population for Bramham Medical Centre, we do have some difficulties with GP registered populations, the actual numbers. That's why we're currently not able to update the PHM data packs, because the kind of list size that we have in the data model is too big. There's something not quite right, but and then all the other data would give a spurious position. So that's why we're not able to update it at the moment. So that's the data pack. So, oh, someone else has popped on. Hi. So I know you haven't got a microphone, but is there any questions, any things that jump out at all? No, and that's cool too. So I can circulate, or Lynn can circulate that data pack. But really, this is just it's kind of the first point of looking at how we can maybe do things differently within Wetherby, within this frail cohort. So essentially, we're going from the whole of Leeds, of however many 100,000 people that is. Then we're breaking it down into the Wetherby Local Care Partnership. Then we're breaking that down into the frailty cohort. Then we're breaking that down possibly into a moderate frail cohort, and then possibly looking at, Holt Park, or looking at falls. What's happening with those people who are falling over? Is that medication reviews, or actually can we improve how? Because we know that people do fall over and they don't report that they fall over, and that's possibly not a good thing as well. So actually we might try and encourage people not to fall over, but if they do fall over, to report that they've fallen over, and then maybe we can do, we can help them in some way. Can we see? Well, it's to answer your question, Sophie. It's not necessarily an underspend. It's just we spent less, and again, that could be good. It could be bad. I'm not entirely sure. It's just, I suppose, a function of the care that we're delivering to those people. I do know, for example, that spend in Wetherby on community, like LCH, community nursing, is really low. Try to unpick that with not much success. I think it's kind of just the way it is, based on the population and the overall health of the people living in Wetherby, that for some reason they are potentially a bit more, just a bit more healthy, and they don't need so much community care as opposed to Beeston, Middleton, that sort of thing. So I think it's really a function of the people and the demographics, and I suppose I can't think of the right word. Yeah, it's more to do with demographics. It's not that they're getting a poor service from LCH. It's just a different mix of people and mix of stuff that they need. So no, we've not got a whole heap of cash in the bank just waiting to go, oh, let's spend this in Wetherby. That's not what I'm saying. It's just we're different to the Leeds position, and we should be interested in why that is. So yeah, hope that answers your question. There is no more money, I don't think. Okay. But if you've got any other questions, if you're lying awake in bed at night and you can't sleep and you've got data on your mind, just fashion an email, let me know, and we can always do a bit more digging. We're now interested in health inequalities. Well, we were interested in them anyway, but health inequalities in Leeds is becoming more of a focus, and actually you can take the Wetherby PCN or whatever PCN and actually break that down further into more kind of neighbourhood based activity. to say, well, actually, in this particular lower level super Alp area or neighbourhood, there is a higher prevalence of this thing. Maybe we should do some targeted work for the people that live there. So that's sort of one of the next things that we're trying to present data in that index of multiple deprivation way.
Graham, has any of the other PCNs done that work yet around those really super output areas, sort of those lower super output areas?
They have indeed, and that's a very good question. I can show you something actually, because I'm just doing some stuff for Woodsley and Holt Park, if you just bear with me. So you should be able to see another slide deck opening. So can you see now a slide that says Woodsley IMD? So again, we're able to break all that data down from the Leeds data model into deciles because we know where people live. We don't know what house they live in. We don't need to know that, but we kind of know the postcode or the lower level super output area that they live in. So we're able to slice and dice this stuff into geography and break it down. So one of the ones, so Woodsley, for example. So this is just a spread of the moderate frail cohort by deprivation decile. So you can see here that the largest percentage of people with moderate frailty in Woodsley live in IMD decile 2. So it's kind of towards the most deprived end, but Woodsley and Holt Park meet together as an LCP. So if you keep that bar chart in mind, that's the similar data, but for Holt Park, and it's really different. So again, we could probably assume, but actually this was a bit of a moment for me, that Holt Park and Woodsley are really different. So in Woodsley, most of our moderate frail people live in the most deprived areas, whereas in Holt Park, by a long way, most of our moderately frail people live in the least deprived areas. So again, we're focusing on these health inequalities, and this shows it really, really well. You know, we've done a load of work on the shielding population. So, you know, there's 44,000 people in Leeds that have been asked to shield. And again, if you break that down by IMD, most of the people by a huge margin live in the most deprived areas. So hopefully cutting the data like this shows you that there are health inequalities, and it's kind of, what are we going to do about this? Because this is serious stuff. You know, it links to the agenda in the city of improving the health of the poorest people the fastest. So it's a real thing. I don't have any other more eloquent words, but it's a thing that we need to pay attention to. And we can also map where these things are. So if you can see, so that's Holt Park primary care network, and those are the shaded lower level super output areas by decile. So the red are the most or the more deprived areas, but in Holt Park, most people live in the least deprived areas. So then we can just highlight that. So maybe we can target those particular areas rather than a blanket approach. Let's kind of always narrowing down our cohorts to the people that need us most. So, you know, it's up to the kind of the PCNs and the LCPs to decide kind of what that means, but I can present data in all sorts of different ways that hopefully will draw out some kind of pictures and some stories. So
yeah, I'm involved in the Holt Park Woodsley PCN around the fall stuff, because obviously my team deliver the strength and balance programs across the city, and we've had these particular discussions around the specific Holt Park demographic is very similar to the severe frailty in Wetherby, isn't it? Where the most least deprived people are actually the most frail. Yeah. Which is very different to the areas that we're used to be working in around, you know, the inner city 1% areas. Yeah. But there are people within that 1% areas that are frail. It's just a completely different. The age range is really different.
Yeah, I was going to say age is interesting. So in the more deprived areas, the age of frail people is younger, Whereas, as we see, so Holt Park and Wetherby, probably Otley and Yeadon, the frail people are older. And again, I think we probably know that because it's just people move out into more affluent areas and stuff like that. But I think it's really interesting just seeing it as well, and you kind of go, oh yeah. So hopefully it's those kind of light bulb moments.
I basically need this data to say back to my boss to say, actually, we do need to deliver some things in the more affluent areas, because obviously being told, no, you can't do that. But actually the need, if you look at different populations, is actually out in those communities.
Yeah.
And while the interventions might look completely different, it's where we put our services and our resources to, and yeah, this is really interesting for me. If you've got any of that, and this is quite specific to sort of counteract some of the conversations we're having within sort of our area of sort of city development, is around these, being data driven rather than being, that's the most deprived area, we're just going to put some resources in there, because that doesn't always work.
It doesn't. Yeah. No, you're absolutely right, because older, more affluent people in Holt Park are, so that's my next thing that I'm going to do. I'm going to pull out the falls information and then say, okay, where are those people falling over? Where do they live? Because I had a hypothesis that they were all falling over outside Asda, but I don't think that's true, which is really disappointing because I wanted that to be a thing. But yeah, so where do the people who are older, more affluent, probably the wrong word, but you know what I mean, where and why are they falling over? So it's all about creating smaller manageable cohorts to understand how we can proactively help them, because we're really good at putting in services to fix stuff, but that's a reactive thing. So we need to be more proactive to head stuff off before it happens, to stop that massive elective spend in hospital, because it costs a lot of money. And if we can move that cost out into the community, then that's better for everybody, because no one wants to go into hospital if they don't have to.
And they're not at the moment. That's the thing.
Well,
that's COVID.
And falls have gone massively down. I saw some data about falls since lockdown, and obviously they've just plummeted because nobody's going out. But I'm not saying that the future of falls prevention is just making everyone stay indoors, because that's not good either. But the data says that people when they go out, they fall. Yeah. Because they're currently staying in. So
I think it's more about, and especially in that area, when they go out, they fall, and they do fall in Asda, and it's only reported when they get the ambulance in Asda, because that's where they all go shopping. Yeah. So it's a hot, I can see us putting loads of rails up in Asda and things just to stop people falling over, and having wider trolleys and all that sort of stuff. But
if it was only that easy, because that would have been a great project. But I don't think it's a thing, unfortunately. But yeah, so it's that kind of, again, just asking questions about why is that happening? Why are the people there? What's different about those people? How can we engage with them and ask them what sort of support do you need? So yeah, it's interesting. So as I say, I'm just doing this data for Woodsley and Holt Park, and the next thing will be around where do the people live who have a high prevalence of falling over, because they might live on a hill. That's what, we all know that the weather in Holt Park is completely different to the rest of Leeds, because it's higher up and it snows all the time and it's wet and all that sort of stuff. So yeah. Any other questions? Cool. Right. That's all right then. Well, thank you very much for your time. Hopefully that was useful, and we'll circulate these data packs